The problem most seniors miss: NSAIDs plus aging kidneys. Most people think NSAIDs, ibuprofen, naproxen, diclofenac, just tame pain and swelling. The thing most people miss is how they do it. They block prostaglandins, the tiny messengers that also keep kidney blood vessels open when you're stressed, low on fluids, or your pressure dips. That's fine when you're 30 and fully hydrated. After 60, kidney reserve naturally shrinks. Block those prostaglandins, and you squeeze the incoming arteriole, drop filtration pressure, and quietly reduce your glomerular filtration rate. You won't feel that squeeze. Your labs will later. This clicked for me when I realized prostaglandins are the kidney's backup plan. When volume is low or stress is high, they dilate vessels to maintain flow. NSAIDs remove that safety net. If your baseline eGFR is already lower with age, your margin for error is thin. Add heat, illness, or skipped fluids, and the same, safe, dose hits much harder. Now here's where most people mess up. They equate as directed with safe for me. Labels assume a healthy adult with no interacting meds. Many seniors take ACE inhibitors or ARBs for blood pressure, and diuretics like furosemide or hydrochlorothiazide. That combo relaxes the kidney's outflow and pulls down volume, while NSAIDs clamp inflow. That triple whammy can drop filtration fast. Even without all three, a hot day or stomach bug can turn a routine dose into a kidney-straining event. Quick pause. Why does this matter today? Because early kidney effects show up within hours to days. Reduced blood flow, sodium retention, and a bump in blood pressure. Stack those hits across a heat wave or a flu, and you tip into acute kidney injury. You might bounce back, but each hit can leave a small dent, less reserve for next time. Over months to years, dents add up to a steeper eGFR decline than expected for age. Let me open a loop you need to hear. The first 30 days of daily NSAID use are often the most dangerous for seniors, especially if you're also adjusting blood pressure meds or recovering from illness. I'll explain the timing trap in a minute, but first, the silent signs people ignore. You can take an NSAID, feel better, and assume all is well. Meanwhile, inside the nephron, sodium and water retention creep up, blood pressure inches higher, and filtration dips. Early clues: tighter shoes by evening, a pound or two of sudden weight, darker urine when you've been active, or fewer bathroom trips. Sometimes you notice nothing until a routine test shows creatinine up and eGFR down. That "I feel fine" window tempts daily use. And that's the trap. Access makes stacking easy. OTC status means you can buy it anywhere, and the same ingredient hides across brands. One says arthritis pain, another sinus, another PM. It's common to double dose without realizing it. The mistake that ruins everything is grabbing a daytime sinus pill with ibuprofen, then a PM pain pill that also has ibuprofen, 2 loads in 12 hours, on top of a dehydrating day. Here's the shortcut nobody teaches. Connect 3 facts before any dose: your age and kidney reserve, your hydration today, and your current meds. Over 60 with hypertension or diabetes. Strike 1. Fever, vomiting, diarrhea, heavy sweating, travel, or fasting. Strike 2. ACE inhibitor or ARB plus a diuretic. Strike 3. Skip NSAIDs unless your clinician explicitly clears them. Let me show you exactly how this plays out. A 68-year-old with knee pain takes ibuprofen during a heat spell, keeps gardening, and drinks coffee instead of water. Pain improves, but by day 4 his ankles puff, blood pressure jumps, and urine darkens. Labs show creatinine up, eGFR down, classic hemodynamic strain. He stops NSAIDs, hydrates, and recovers. Repeat that cycle a few times a year, and recovery becomes incomplete. Small dents, real loss. Now, the timing trap payoff. The dangerous window often opens when routines shift. You start a new blood pressure med, add a diuretic, catch a virus, or travel. You're already low on volume or altering kidney blood flow. Add an NSAID, especially duplicated in a combo, and you amplify the squeeze exactly when you need the prostaglandin backup most. That's why the first days and weeks of "I'll just take one" daily spike risk. Common red flags that your kidneys aren't happy after NSAIDs: swelling in feet or hands, rings that suddenly feel tight, a noticeable blood pressure bump, darker urine with fewer trips, unusual fatigue, or brain fog. Anyone can have other causes, but 2 or more, especially after a couple of NSAID days, are your signal to pause the drug, push fluids with electrolytes, and call your clinician. If you remember nothing else from this section, remember this trade-off. NSAIDs help pain by blocking prostaglandins, but after 60 your kidneys rely on those prostaglandins to keep blood flowing under stress. Remove the safety net during dehydration or with the triple whammy, and you trade short-term relief for long-term reserve. Up next, we'll decode labels and expose the duplicate dose landmines most people miss. Why labels don't protect you after 60. Let's crack the label code, because this is where good intentions get people hurt. The front says fast relief and long-lasting, but the safety math lives in the fine print, and it's not written for aging kidneys, multiple meds, or dehydrated days. Start with the assumption baked into every bottle: a healthy adult, normal kidney reserve, steady fluids, and no interacting drugs. That's not most people over 60. Your filtration is lower, you're more prone to dehydration, and you're often on blood pressure meds. Same directions, very different risk. The thing most people miss sits at the top of the drug facts: the active ingredient and milligrams. Ignore the brand. Say it out loud. Ibuprofen 200 milligrams or Naproxen 220 milligrams. 2 bottles, 2 different promises on the front, same NSAID inside. Buy both, and you've doubled your dose without knowing. Now, the booby traps, combo products: PM, sinus, cold/flu, and migraine formulas often tuck an NSAID next to a decongestant, antihistamine, or caffeine. You think you're rotating, but you're repeating the same NSAID. Daytime sinus tab at breakfast, PM caplet at night, 2 NSAID loads in 12 hours, plus your separate pain tablet at midday. That's duplicate dosing in plain sight. Here's where it gets sneakier after 60. Timing and interactions don't show up on the front. ACE inhibitors, or ARBs, like lisinopril or losartan, relax the kidney's outflow. Diuretics like furosemide or HCTZ pull volume down. And NSAID clamps inflow. Together, they can drop filtration quickly. They triple whammy. Low-dose aspirin adds confusion too. Aspirin is an NSAID for platelets, not pain. Taking ibuprofen near it can blunt aspirin's heart protection while still stressing kidneys. Labels won't explain that timing puzzle in simple language. Let me show you a 30-second scan that protects you. Step 1, active ingredient and strength, name it out loud. Step 2, directions, max tablets per day and spacing. Step 3, warnings, hunt for kidney dehydration, diuretics, high blood pressure, heart failure, and age. Step 4, other ingredients. Pseudoephedrine or phenylephrine can raise blood pressure. Diphenhydramine sedates and hides pain signals. Step 5, check your shelf. Do you already have a product with the same NSAID? Open loop you need to close right now. The label assumes you're tracking totals across every product in your house. Most people aren't. That's how 1 a day becomes 2 or 3. Fix it with a tiny med log, paper or phone. Each time you take something with an NSAID, write the time and milligrams. Do the same for acetaminophen. Cold and flu combos hide it, and double dosing acetaminophen shifts the danger to your liver. You might ask, can't I just pick a safer NSAID? Honestly, swapping brands won't undo age, dehydration, or the triple combo. Your risk profile and today's fluid status drive safety more than the label. That's why 2 people can take the same dose, and only one gets into trouble. Context. Micro story to make this stick. A 72-year-old grabbed a sinus day and PM pain during a head cold, plus his usual arthritis tablets. He thought he was rotating. All 3 listed ibuprofen in tiny print. He slept better, but by day 3 his ankles puffed, his blood pressure jumped, and his urine darkened. The front labels helped him pick. The back labels would have kept him safe. Here's the shortcut nobody teaches. Run a pre-dose checklist. 1. Age 60 plus with CKD, diabetes, heart failure, or hypertension. 2. On an ACE inhibitor or ARB, a diuretic, aspirin, anticoagulant, or steroids. 3. Dehydrated today from fever, vomiting, diarrhea, heat, travel, or fasting. Any yes moves you out of the green zone. 2 yes. Avoid oral NSAIDs. Choose a topical first or acetaminophen within your limit. 3 yes. That's a hard no. Talk to a pharmacist. Make the pharmacist your ally. Say your age, meds, and kidney history, then ask 3 questions. Is there an NSAID here? Does it interact with my ACE/ARB or diuretic? What's the safest option for my kidneys today? In 5 minutes, they'll often steer you to diclofenac gel, a clear acetaminophen schedule under 3,000 milligrams, and a hydration plan. One last trap: effervescent or soluble rapid tablets can be loaded with sodium. Pair that with NSAID-driven fluid retention, and blood pressure rises fast. After 60, that's a double hit you don't need. If you remember nothing else here, ignore the front, read the active line, hunt duplicates, track totals, and ask a pharmacist when you've got any kidney, med, or dehydration flag. Labels protect healthy, hydrated adults. You need a plan. The silent damage timeline, from first pills to lasting loss. Let's map what actually happens, because the pattern is sneaky and it starts fast. Within the first few doses, NSAIDs reduce prostaglandin support, the kidney's inflow vessel tightens, and filtration pressure dips. You don't feel that. What you might notice in 24 to 48 hours is subtle fluid retention, shoes a bit tighter by evening, rings that don't slide, a quick 2-pound uptick on the scale. Your blood pressure can creep higher because you're holding sodium and water. If you're also a little dehydrated, urine darkens, and you go less often, pain feels better, so you keep dosing. That's the false green light. Now, here's where most people mess up. They expect the body to adjust to daily NSAIDs. It does, but not the way you want. Each bout of reduced kidney blood flow is a small hemodynamic hit. Stack hits through a heat wave, a stomach bug, or long travel, and you tip into acute kidney injury. That's when labs jump, creatinine rises, eGFR drops. You may feel wiped out, lightheaded, or mildly confused because waste products aren't clearing well. Stop the NSAID, hydrate, rest, and you can recover, but not always to the same baseline. Once you nail this picture, the long game clicks. Think dents. Every acute hit can leave a small dent in reserve. You might bounce back on paper, but the cushion shrinks. Over months to years, repeated dents make your eGFR slope steeper than normal aging. Day to day you feel fine, which is why this timeline fools smart people. Open loop you need to close. The first 30 days of "I'll just take one daily" are a hotspot. Why? New habits collide with shifting physiology. Med changes, illness recovery, travel dehydration. Add a combo product that duplicates an NSAID, and you've amplified the clamp at the worst time. I'll show you how to sidestep that in 30 seconds, but watch how the timeline spirals. Micro story. A 70-year-old on losartan and HCDZ starts morning ibuprofen for shoulder pain. Week 1 is fine. Then a cold hits, fever, poor appetite, less water, sinus day in the morning, and PM pain at night, both hide ibuprofen. On day 4, ankles puff, BP is 16 points higher, urine darkens, and he's peeing less. He blames the virus and takes another PM dose. Labs the next day, creatinine up, eGFR down. He pauses NSAIDs. Hydrates, recovers partway in a week. 2 months later, a heat spell plus yard work repeats the story, and the dent deepens. This next part separates beginners from pros, catching early red flags and acting fast. Watch for clusters, not one-offs. Rapid weight gain in 24 to 48 hours that isn't food-related new or worsening swelling in feet, ankles, or hands, a noticeable bump in home blood pressure on NSAID days, darker urine plus going less often, unusual fatigue, brain fog, or mild shortness of breath 2 or more after a couple of doses. Pause NSAIDs. Push fluids with electrolytes, elevate your legs briefly, and call your clinician for guidance and possible labs. Waiting to see if it passes is how a small hit turns into a bigger one. Let me show you the predictable stress plus NSAID moment so you can dodge it. You're mostly fine on occasional low doses. Then add one stressor: fever, vomiting, diarrhea, heavy sweating, fasting for a procedure, or long travel, and your blood volume drops. Pair that with an ACE inhibitor or ARB and a diuretic, and inflow-outflow balance is already delicate. Take an NSAID, especially a hidden duplicate in a combo, and filtration can fall fast. That's the timeline's trapdoor. Here's the shortcut nobody teaches. Build a 48 to 72 hour pause rule. If you've had GI losses, fever, heavy sweat, long travel, or a diuretic day, skip NSAIDs for the next 2 to 3 days while you hydrate and reassess. If you're on an ACE inhibitor or ARB, be even stricter. Once urine is pale and frequent again, your blood pressure is back to your normal, and swelling is gone, only then consider a brief NSAID rescue. Lowest dose, 1 day if truly needed. Another micro story for the payoff. A 69-year-old with knee OA kept a simple BP and urine color log whenever he used a rescue dose. On a hot week, after daytime yard work and a PM pain tablet, his evening BP hit 156/92, ankles puffed, urine browned. He paused NSAIDs, used diclofenac gel and timed acetaminophen, added electrolytes, and called his clinician. Labs showed a small creatinine bump, caught early, back to baseline a week later. He rewrote his plan: topicals daily, acetaminophen within 3,000 milligrams, rescue NSAID only on cool, well-hydrated days, rarely needed. If you remember nothing else from this timeline, remember this: NSAIDs can cause a hemodynamic hit within hours, repeated hits leave dents, and dents add up to real, lasting loss. Catch clusters early, pause during stress, and treat duplicates like landmines. Next, we'll connect your kidneys to your heart and stomach, the triangle that turns a simple pill into a system-wide problem.